Good morning. The session is ready to begin. The session is sponsored by Peterson Center on Healthcare. Thank you to Peterson Center on Healthcare. Pat Merriweather-Argis from the Project Patient Care will moderate this session. Pat, you have the floor.
Thank you. And good afternoon, everyone. And I'm glad you're joining us. And again, this is all new technology and opportunities for us to work through this together. So bear with me a little bit, and I think this will go fine. I just want to talk about, this is the session on bridging data and policy. And I think this is a tremendous opportunity to really understand how data and policy, how they work together, they affect each other, as well as they drive initiatives. And today I'm very excited about this session because I love the idea that data can influence policy and data can also monitor the policy implications as well. And with us today, we're going to crisscross the nation. We have Lisa Miller from Comagine Health, Angela Taylor from the Kentucky Cabinet for Health and Family Services at the U of Kentucky, Charles Bentley, the Hilltop Institute of Maryland, Baltimore County, and Vinita Ball from the Center for Improving Value in Healthcare. So you're going to go from, Oregon to Kentucky, then to Baltimore, and then you're going to go back to Colorado. So again, a great opportunity to get to know the rest of the nation and what's going on. The goals today, the objectives are really to understand and support the value of data driving policy development and, as we said, monitoring. And also the value of increasing transparency to patients, consumers, providers, health plans, and state agencies. As we know that we are in a transparency era, and the more information people get, the more they want. So again, this is a never-ending initiative. And then also making sure people understand not only us, but as we talk to others, how useful data is in the variety of decision-making policy initiatives that take place. So with that, I'm going to turn the screen over right now to Lisa Miller, and she's going to begin the session. Each presenter will have 10 minutes, followed by 5 minutes of answering your questions. So please, please, please use the Q&A, use the chat, but especially the Q&A, and we'll be able to respond to your questions. Lisa, it's all yours.
Great, thank you very much. Can you please confirm that you're hearing me?
Yes, perfect.
Perfect, thank you everybody. All right, I'm Lisa Miller. I'm the Data Collaborative Manager at Comagine Health in Oregon, and I'm talking with you today about an analysis we did looking at the impact of the Comprehensive Primary Care Program in Oregon. Comagine Health is the recent name of several different organizations that merged over the last few years. So you might have known us as Oregon Healthcare Quality Corporation, or QCOR, or Qualis Health, or Health Insight, or a few other organizations as well, that all merged to become Comagine Health. Now we are a national nonprofit healthcare consulting firm. We run the voluntary all-payer claims database for the state of Oregon. In our data set, we have about 80% of fully insured commercial population, 23% of the self-insured, 100% of Medicaid, and 87% of the Medicare population, including fee-for-service and Medicare Advantage. So overall, we have about 80% of Oregonians represented. I'm sure many of you are familiar with the Comprehensive Primary Care Program, CPC Classic, and more recently, CPC Plus. Oregon has been a participant since Classic began in 2012. We are one of the co-conveners for the CPC Plus payer group in Oregon, which consists of 12 payers, including CMS. And beginning in 2018, we have also been the data aggregator for the Oregon region. An analysis by Mathematica a few years back, where they looked at the impact of the CPC Plus program in the Medicare fee-for-service population, really sparked our interest in trying to think about how we might be able to assess the impact of the program ourselves. Then there were some analyses from the Health Collaborative in Ohio that demonstrated how APCD data could be used to produce meaningful analyses using multiple payer types. In collaboration with the CPC Plus payer group, we developed a plan to produce data bites. That's what we call these 2 to 3 page infographics that really focus on one research question. They're faster to produce than a full-scale evaluation would be, and they meet stakeholders' needs to have something that's really easily digestible and easy for them to share with their other internal audiences who might have limited time and attention to read in-depth documentation. In brief, our methodology was to look at the CPC participating group, which was Oregon primary care practices that participated in both CPC Classic and CPC Plus. And we compared them to a group of the Oregon primary care practices that participated in only one CPC program or did not participate in either. We suppressed any denominators with small numbers. The data were from 2017, so this was a snapshot in time analysis at this point. And we have Medicare fee-for-service data available to us through our participation in CMS's qualified entity program. So a complete description of the methodologies for the 2 data bites that I'm talking about today, as well as the complete results, are available on that Oregon CPC Plus payer group website that's linked here, and I'm sure we'll be able to make it available as well. As we started to think about what do we really want to look at, we developed our research questions collaboratively with the payer group and with CMS and Deloitte. And the first research question that we came up with was, is participation in CPC programs associated with any changes in the quality of care that's provided? We found that it is. CPC participating practices had higher performance rates than the comparison practices on 24 out of 26 measures, and that was when we looked across all payers. The difference was statistically significant for 14 of those measures as well. I realize it's hard to read those. The complete data bites are also available at the CPC Plus payer group website, and you'd be able to download and share them as you like. So in general, this list of measures are measures that are of interest to a broad group of stakeholders, and they group into some general categories: medication management, antibiotic stewardship, preventive screenings, diabetes care, low value care, behavioral health, and opioid usage. We pulled out just a few of the really high interest measures to visualize them in more detail for the data bite. So an example of those is breast cancer screening and cervical cancer screening. You can see the green dots represent practices participating in both Classic and CPC Plus. And then the gray dots are the comparison practices. And in every case, across all payers and each individual payer type, the participating practices had higher performance rates than the comparison practices. In breast cancer screening, the difference was statistically significant for every payer type. And in cervical cancer screening, it was significant for commercial and for all payers, as you can see by the asterisk right after the numbers. Our next research question was, is participation in CPC programs associated with any changes in the utilization and cost of healthcare? We did find that participating practices had significantly more adult outpatient visits than comparison practices. That was statistically significant across all payer types. This is probably to be expected given that CPC Plus the CPC program has a focus on primary care transformation. We looked at utilization as well. The emergency department utilization was much lower among participating practices than in comparison practices for both number of ED visits and for avoidable ED visits. And the avoidable ED significance varied by payer type, but for the ED visits overall, it was significant across every payer type. We also looked at cost. Now, we saw a reduction in costs among patients at CPC participating practices compared to the comparison group. But I want to point a couple things out here so that this result can be clearly understood. First of all, these costs are risk adjusted using the Johns Hopkins ACG risk adjustment. Secondly, we're only permitted to report costs with data from our commercial payers. So we were only able to include the commercially insured patients in this analysis. And thirdly, our database is claims-based only, so we do not have the dollar amounts from any alternative payment methodologies. To minimize the impact of this, we looked at facility costs, which are claims-based. So this analysis that you see here is just the claims-based facility costs of emergency services, inpatient services, and outpatient services. Does not include any professional fees, does not include any APMs. But by looking at these facility costs, we really are able to compare apples to apples between the CPC participating and the non-participating groups. And we see that patients had lower per member per month costs, and it was statistically significant across each setting. So those are our results. What does this all mean? We found that CPC program participation is associated with improved quality, cost, and utilization, in many cases statistically significant. The resulting analyses enable us to look at care transformation that the CPC program was working towards and the practices participating in CPC were working towards at the population level. So looking across almost all of their patient population to see what differences we were able to see. Some payers who are participating in CPC were not able to see the change, any delta in their data by looking at just their own data when they looked at CPC practices versus non. It really took looking at aggregated multi-payer claims data to be able to see the impact of the program overall. Additionally, the pandemic has really put a spotlight on just how inadequate fee-for-service models are in sustaining primary care. It feels really timely that we are able to show right now that this broadly adopted value-based payment approach that CPC Plus is, has had a significant difference in improving the quality, utilization, and cost of care in Oregon, at least. So next up for us, the payer group has requested 5 more data bites over the next year and a half-ish. We're going to take a look again at primary care quality, cost, and utilization, but looking at trending this time. So we'll take a look at 4 years of data and really be able to see a better insight into the impact of how long practices have been involved in the program. We'll also take a look at some behavioral healthcare quality, utilization, and cost, and we'll take a look at care transitions as well. We're working on developing the research questions. We're working collaboratively, again, with the payer group and CS and Deloitte, just as we did for the first 2 data bites. So we're looking forward to having some really interesting results coming out from those over the next several months. So to wrap things up, I'll say that the importance of analyses like this really can't be understated. For example, Oregon's Primary Care Payment Reform Collaborative has stated that CPC Plus Track 2 is the model that they're following for statewide primary care reform. We at COMAGIN have really close ties to this policy group. Many of our stakeholders sit on that committee as well as on our advisory committees. And our hope is that the transparency we're providing will inform that group and other policy groups in order to inform their efforts to transform healthcare in Oregon and possibly even nationwide. Thank you very much.
Thank you, Lisa. And we do have a few questions for you.
Great.
The first question is, were both groups claims risk adjusted for the cost analysis or only CPC?
Well, that wouldn't be a very fair comparison, would it? So both groups are risk adjusted, exactly.
Okay. And do you know what were the driving factors within each organization or within the different organizations that really drove the performance? What was there any analysis as to the interventions or the strategies or the initiatives that drove the variation?
This is a quantitative study. So we really were looking just at the claims. We have thought about, could we do a qualitative study and partner with the CPC Plus Regional Learning Network in the Oregon region to do something more qualitative. We ended up not having the budget to do that in this next group of data bites, but that was exactly the question is, especially when we look at something like reduced ED utilization. That's fantastic. How did you get that to happen? So we can try to reproduce it somewhere else. We didn't do that study. There are lots of other people working on gathering that information. I know CMS does surveys regularly, and the Regional Learning Network is working directly with practices that are involved to try to gather that information as well.
Okay. And at some point, it'll all get merged together?
Hopefully, yeah. I mean, I think when we, our data now exists and we've done this analysis, so we'll be able to look at, as a qualitative analysis looks at changes over time, you know, what care transformation efforts did you put in place over time? We could pretty easily line those up with the data that we saw at that time.
Okay. And one additional question, and what is the beneficiary reaction to this? Has that been measured? Are there plans to measure it? Or are they not part of the equation?
The beneficiaries were not a part of our evaluation. Again, it was quantitative. To be honest, I don't know if there have been efforts to find out how beneficiaries are feeling about the CPC programs in general. Again, that would be a really fantastic, really meaningful qualitative study to take a look at.
Yeah, because they're the ones that can spread the word about how much they liked it and enjoyed it and benefited from it.
Mm-hmm.
Okay.
Absolutely.
Well, this is great. And at the end, you know, we'll probably have a few minutes left. So if you have any additional questions, please consider, there is one in the Q&A. Did you look at baseline performance level prior to participation in CPC? Specifically, do you know if there were baseline performance differences between participants and non-participants?
That's a fantastic question, and we did not. For this study, we were looking at a single year and comparing the two groups. Part of the issue is that CPC Classic began in 2012, and we feel very confident in our data going back to about 2015. So if we were to look just at the practices who joined one of the CPC programs after the time we have data, that would limit the number of practices we were able to analyze. But it certainly would be something that we could take a look at. That's not what we're doing for the next set of data bites either. We're going to be looking at trending, keeping the comparison groups the same so that the next set of data bites build on the analysis that we've done so far. But yeah, there could definitely be some selection bias into which practices decide to join CPC versus which ones don't.
Okay, well, thank you so much, Lisa. I really appreciate it. And you'll be around, so if you have additional questions for Lisa, you can put it in the Q&A box, and we'll be able to also answer some more at the end. I'm now going to turn it over we're going to go over to Kentucky now, and Angela Taylor is going to talk to us about what's going on in terms of databases to policy spaces. It's all yours, Angela.
Hi, good afternoon. So first I want to I'm going to talk to you a little bit about Kentucky's aspirations to become more evidence-based without an APCD. To begin with, we'll talk about evidence-based policy and the role of administrative data informing conclusions, how the Office of Health Data and Analytics specifically serves the Commonwealth, and give you some examples of some projects that we've done. So what does a Kentucky look like? I'm sure you all know that Kentucky generally falls in the lower part of their rankings throughout the United States. We are currently ranked in 43rd. We have been ranked as low as 47 or 48 in the past, so we are making some strides to improve our outcomes. If you look at these specifically, our strengths are we're 4th in the nation in graduation rates and 9th in rates of uninsured citizens. And you may remember that Kentucky actually made national news when we expanded for ACA. We have very severe challenges like smoking and cancer. These are big issues in Kentucky. So how does Kentucky fall in the arena of evidence-based policy? So this is the Pew MacArthur Results First initiative, and Kentucky's actually currently ranked modest. So for Kentucky to be healthier, Medicaid beneficiaries are going to be the most effective for us. They're going to have the greatest gains. In Kentucky, Medicaid covers almost 1/3 of all citizens and almost half of all children. So Medicaid policies just by themselves could have a very dramatic impact. So what does it mean to be modest or leading? This is how they defined it in the Pew MacArthur Results First study. Define levels of evidence, compare programs, report outcomes, all of this information. So if you compare us to, let's say, Washington. Washington is currently ranked 9th in state health outcomes, and they are leading the nation in evidence-based policy. Do those things matter? I didn't do that study, but it seems like they're correlated. Washington actually has written into their laws that certain high-level policies must undergo a cost analysis before they can be enacted. So Kentucky wants to be like Washington, be more evidence-based, have more data influencing policy. So Kentucky's policymakers need fast and effective analysis. So that may be very small pieces of data, and it may turn into large-scale academic manuscripts. Our largest data set that we currently have is Medicaid claims and enrollment. We are in the process of adding our health information exchange data, but as we all know, integrated data equals enriched analysis. So we don't just study claims and populations, we also want to look at cost. That's an important issue. So we do financial impacts and of potential and already implemented policies. So here's a sneak peek of one that we are currently finishing. We are actually attempting to publish this paper as well because we found that it was very useful and novel research. So Kentucky's leading the country in the number of syringe services programs. The Department of Public Health asked us to help them support the case that SSPs were effective and had a measurable impact. We looked at the rates of infectious disease and found that in a pre and post analysis that there is an association between SSPs and infectious disease rates. Counties that have an SSP see a 0.5% decrease each month after an SSP opens. So that's where we're at, the Office of Health and Data Analytics. Cabinet leadership has decided that investing in internal analytics could benefit decision makers and also be cost effective for taxpayers. So integrating all of the data sets has been an ongoing work for several years, but the Office of Health Data and Analytics was created in 2015 and formalized into statute in 2019. With the lofty goal of study and report on healthcare and social services for the Commonwealth. So not just Medicaid, for the entire Commonwealth of Kentucky. In support of that goal, we created a multidisciplinary team in order to provide different views and perspectives on the research and analytic questions we receive. We have IT professionals, data analysts, healthcare data administrators, statisticians, academic researchers. We really want to get as many different viewpoints on the research questions that we receive as possible. This is our data model, our current and future data model. So we're the blue. So robust health analytics requires more than just a person's interactions with healthcare professionals. Integrated data that informs other areas of their lives could offer better understanding of the needs and outcomes. So with that, this is our goal, is to create this more integrated data set. We're looking at, this is us in the middle, we're blue. I should have made that bigger because it's a lot of data, but we actually have vital statistics, birth and death certificates, enrollment, Medicaid claims, CASPR, which is our prescription drug monitoring program. So we can actually look at scheduled drug prescriptions, both within Medicaid and externally. We share data with the Kentucky Cancer Registry. We have TWIST data, APRIS and corrections data to help understand justice-involved individuals. And we're including our identified healthcare facilities data, which will give us all hospital discharge data for the entire state of Kentucky, not just Medicaid. That isn't, of course, professional claims, it's just hospital claims, but it will help in our understanding. So here's a little bit of the things that we've done. in order to support this. So we are creating an infrastructure to integrate all this data, providing data analytics and research to policymakers. We're working with external academic partners via our state university partnership. We also support major national, federal, and NIH grants such as HEAL and Modern. And we provide program evaluations for things like Family First and other, our FRISC program, which is services offered to children in schools. Here's an example of a project that we recently finished. So hepatitis C treatment in Kentucky was pretty restricted. In order to be approved for treatment, you had to have a chronic hep C diagnosis, a high F score, and clean drug screens for 6 months. So after they relaxed these requirements in 2018, any hep C diagnosis would be approved for treatment. So this is what that looks like for us. This is the amount of treatment. So you can see this big uptake in July of 2018. That's when that policy became effective. So we're treating a lot more people, but how does that affect what we pay? Not the way you'd expect. We're actually paying less per person for treatment, even though we're treating way more people. This is a big part for us because, you know, the opioid epidemic Kentucky is very hard hit in this area. It's the epidemic within the pandemic, right? This is still going on for us, and it's a huge issue in Kentucky. So in support of Kentucky's opioid response effort, or CORE, we're actually looking at justice-involved individuals, and we've integrated the following, these four data sources in order to try to understand what happens to them upon release. So some of the things specifically that we're looking for are the number of people released, how long it takes them to get re-enrolled in Medicaid, how many died from an overdose and died specifically from an opioid overdose, their behavioral health claims. As you can see, we're also looking at their ER utilization, and we're looking at if they paid cash for prescriptions within our PDMP. In order to really understand what happens when a person is released from incarceration. So this is just a fun little thing about Kentucky. Also, Governor Beshear has made national news, and there's a Facebook group called Andy Beshear Memes for Social Distancing Teens. And if you go look on here, there are literally hundreds of cute memes about how much our state appreciates Governor Beshear's handling of the COVID pandemic. On June 8th of 2020, the governor announced on TV that every Black Kentuckian would be eligible for Medicaid, all of them. So our research department, this is a good example of rapid cycle research, right? So it's a literature review in order to support the governor's initiative. Like, how do we go about doing this? How many people could that affect? How would they like to be reached? How can we enact this change for you? So this was a really interesting one because it was very kind of out of the blue for us. We heard about this on TV, the next day we were working on it. So that's what Kentucky looks like right now. That's what we're trying to do. And our goal is to become more evidence-based in our policy decisions.
Well, thank you. Thank you so much, Angela. And I do have a few questions that have come in. And one is, this is extremely ambitious. It really is, to take the data from so many different sources and to merge it all together. It makes perfect sense. But what's the time frame on accomplishing this?
A lot of this has already actually been done. The data model that I showed you, most of that stuff is already integrated. The things that we need the most now are the health information exchange data. That's currently working now. We should be done with that in the next 3 months or so. I think it's very important that we get EMS data. We actually don't have that yet. And for the use of Narcan, for opioid overdoses. That's a big miss for us. And then the last one is twist data for our foster care and our children.
Now, the other question was, do all of these organizations have access to the data, or is it just limited to your area?
Currently, it's just limited to our area, but that's not the ultimate goal, right? We want to have some self-service analytics. We're looking to include a cloud-based infrastructure to allow people to have access to the data and be able to do some self-service analytics.
Okay, another question is, how did you break down the barriers? Because everyone likes to, have their own data. It's their power issue.
So that's a really great question. And we joke about that the lawyers want to say no, and we try to help them find ways to say yes. So the biggest way that we've broken down this barrier is we're not the owner of this data. We have no desire to control it and make you come and ask us for your data. Your data is your data. You do your analytics how you want. Our goal is to integrate it and help you when you need those services.
Okay. And then the last question is, oftentimes, organizations, agencies get information, and they have the ability, they get funded to collect it and gather it, but not to use it. So do you have access to funds for both of those?
This is a huge issue for us, particularly with our health information exchange, because while the doctors can use it and access it while you're in their office, it was never written into law that it could be used for research. It in fact stated the exact opposite. So we've actually had to change a few laws. Another example is the hospital discharge data. It wasn't individually identified data and could not be linked to Medicaid or any other systems. We had to change those laws. We worked for 2 years to try and change actual statute so that we can integrate and use this data for research.
Okay, and one more question did come in, and it's, how would your work be helped by having an APCD, or are you able to make do without an APCD?
Again, Medicaid covers approximately 1/3 of all Kentuckians. That's a huge number of observations. Those are generally very vulnerable populations, so those are the ones that are going to get the biggest gains. So we can make do, but we can't do things like study cohorts, right? We can't say this is the population versus a commercial insurance population, and we can't really hold MCOs accountable for those health outcomes if we don't understand what's happening in the commercial world.
Okay, so it could be helpful if you had it.
We definitely want it. We absolutely want it, so.
Okay, well, thank you so much. And again, very exciting initiative. And I think there's going to be many eyes on what you're doing, because to be able to pull that together is really a major feat. So thank you. And yet the richness of the analysis is there. So
yeah, thank you.
Thank you. Okay, we're now going to shift a little bit over to Maryland, and we have Charles Bentley, who's going to be talking about some of the initiatives there, especially in APCD. Thank you.
Okay, thank you very much for turning it over. Hoping you can see my demonstration here.
Yes.
Okay, great. I'll just expand it to full screen now. And I just wanted to introduce ourselves as where I work at the Hilltop Institute at University of Maryland, Baltimore County. We are one of those state university partnerships that Ms. Taylor alluded to previously. And the presentation I'm going to give, whereas the previous two were very comprehensive about a state, each of their states' data use, I'm going to talk about a couple of examples where my institution made use of the APCD system in place to work with a smaller piece of the healthcare puzzle, but one that's become a little bit more important in this COVID crisis that we have now. State-based individual marketplaces, as persons may lose employer-based coverage through job loss, they are turning to the marketplace and having some of this work support the existence and financial stability of the marketplace has, we believe, been helpful to that and will be helpful even more so in the future. So I'm going to talk a little bit about Maryland, what makes it different, and talk about the one item of use for APCD, which was to help create the state reinsurance program for exchange policies. There was a problem with, and this happened in several other states, where in the early implementation, costs for individual policies were increasing. And secondly, or third on the items, is the out-of-pocket cost calculator, which we are continually working on to improve, but helps with the enrollment periods, especially the emergency open enrollment period as a result of COVID, which allows individuals to choose insurance products that suit their perceived needs for future healthcare costs. And also that this finally presents an opportunity for 10 states, at least, that we've identified that have both APCDs and which run their own individual marketplace. So, so we are, in Maryland, we have the Maryland Health Benefits Exchange, is its official name, among the 13 states that are state-based. Not all of those states have an APCD though, and most states use the federal marketplace, although that has been shifting slightly over the past few years. We also are fortunate to have a very long-standing APCD that was collected and administered by the Maryland Healthcare Commission. And the third wrinkle is that Maryland is the only state that has an all-payer hospital payment system, that where we have a state agency that sets hospitals' costs and puts them under a global budget. That has pros and cons in different people's minds, but it is one that we've been also using for the past few decades and works pretty well, we believe. But around 2017, our state marketplace was down to only 2 carriers, Kaiser and CareFirst, which was a Blue Cross plan. And out of 25 of our counties, CareFirst was the only option to provide coverage. They, as they submitted their first proposals to the Maryland Insurance Administration for premium rates, they were predicting that they would have to increase their market premiums between 43 and 76%. And part of this was driven by federal policy. There was a defunding of the cost sharing reductions in the ACA. And of course, they eliminated the individual mandate penalty in the ACA. So we worried, many people, policymakers were worried that that would send the individual market into a death spiral. Lower risk members would be seeing these huge increases and they would leave the market to higher risk members, which would drive up premiums and so forth and so on, continually raising those premiums. So proposals were being made to create a reinsurance system to take some of the risk off of those 2 carriers and make the more affordable for consumers to buy at a adjusted premium. So there are a couple pieces to doing reinsurance programs. One issue or point of study that our analysis of the APCD involved was the payment threshold the attachment point where reinsurance kicked in. Basically, what kind of the high level deductible that would cause reinsurance to be needed. The cap, on the other hand, is the absolute maximum that reinsurance would provide, so that protects the reinsurance program itself from excessive costs. Coinsurance, of course, is the rate that is shared, and this is in case it's being shared between the insurance carrier and the reinsurance system that helps to flatten the threshold, the difference between the cost to the individual that's insured and the reinsurance program. So we had options to study where to set the attachment points, where to set the reinsurance cap, and then how to vary the coinsurance rate. But in order to get such a program operational, we needed a Section 1332 waiver under the ACA and prove that it was financially feasible. The Section 1332 allows for waivers to provide higher access, and a number of states have been using these waivers as to implement their insurance program. In Maryland, we used our APCD, the portion of the APCD that covers use and spending in the individual insurance market. We narrowed down the population to just Maryland residents under age 65, of course, individually covered, removed a few product types that made things too complicated in terms of being either catastrophic coverage or that were grandfathered in under ACA. Hilltop combined the total payment amounts across the APCD source across professional, institutional, and pharmacy claims for each individual person enrolled. The data at the time available was from 2015, and then we had to adjust that to project costs into 2019. CMS Personal Healthcare Price Index for costs. We also adjusted for the enrollment. The sample size was adjusted to match estimates that we obtained from the Maryland Insurance Administration. And finally, we had an adjustment for changes in morbidity that were predicted if the prices of insurance changed and made it more or less attractive to a single enrollee. So we compared the average PMPM, the expected value of an insurance premium with and without the reinsurance program. In our model, we came up with estimates of a decrease for instituting reinsurance between 12.4% to 14.5%, depending upon those parameters about attachment points and so forth that I mentioned. Of course, this reduction assumes that when you change the claim cost, that would be passed on to the consumer. When it was implemented, it turned out that our guesstimates were fairly accurate. We had an average premium increase that was approved by the MIA, which was actually a decline of 13.2%. To move on to the cost calculator, we developed a web-based calculator that the exchange, the MHBE enrollment website, can estimate potential out-of-pocket costs. And we use the actual expenditure levels out of the APCD in order to calculate those costs. So this would help them estimate their total spending, both in terms of the premiums that are upfront and their potential cost sharing over the course of an enrollment year. So again, requiring commercial insurance data from the individual market, we made adjustments for geography, age levels, gender, and we used an adjustment for predicted risk of services. Again, we had a lag in the data of APCD. It's in the nature of an APCD that we had to forecast when the enrollment occurs. So we had 2018 data available by this time, and we were planning, we are operating now with enrollment for 2021. So we had to have a 3-year forecast and an inflation adjustment, both for payment rates and utilization. We use the CMS National Health Expenditure Survey expenditures adjustments or predictions for changes in private insurance coverage. This particular source does have the advantage of separating out private insurance from public insurance, and also takes account of volume and distribution of services. Overall, we had a expected 13.7% predicted increase by 2021. We see from CMS occasional annual revisions, and we've built into the model places to take account of that, but they rarely vary more than a few tenths of a percent from year to year. Once we got the data together, we had tested and utilized the distribution of costs with the actuaries working for MHPE, and we wanted to risk adjust. So we took identify low cost coverage at the 50th percentile, a high cost person was at the 90th percentile, and everyone who is 91 to 100% was considered a high cost user. It's interesting and maybe representative of Maryland's, but maybe not. Once you had any hospital use whatsoever in our data set, you would be put into the high cost percentile coverage. So if you were planning hospital coverage to have a baby, you had some surgery that elective surgery you needed, basically you should plan to take the high cost coverage level and get yourself the best deal at that level. To sum up, again, we point out that there are at least 10 states that have both of the pieces that would get them this ability to help their state marketplaces. And this also allowed for greater market transparency in the individual marketplace and allows consumers, and we found that over 80% of consumers who looked at the website also went on to look at the cost of distribution from our model. So we are very proud of that, and we are continuing to work with updates of these data and helping to build it into the system as the system continues now and into the future. And that's it.
That is great, Charles. Thank you so much. And I do know there are a couple of questions, and you know, you got to the last slide and you got piqued people's interest in terms of if somebody has an APCD, the amount of work and methodology and everything that's the Hilltop has built in. Is there a cost for sharing any of the code or methodology, or what's the process for working with the Hilltop?
We are university-based. We do most of our work as a supplement for state agencies. We have a direct relationship with Medicaid, but we also work with the other smaller agencies that I mentioned. The Health Insurance Exchange is separate. So we did this under contract. The APCD is furnished by a different state agency, so we had to gain access to that at a cost. So there's no balancing that number is difficult. The key thing is that the APCD exists. I got to give credit to the MHCC for maintaining and building this system over several years that we can rely on it as a source of data.
Okay, and one additional question that came up is, in terms of the out-of-pocket calculator, that's one that has a great deal of interest right now by consumers. And is that, do you guarantee that's going to be their out-of-pocket cost. I mean, how does that work? Because people become dependent upon using information to try and figure out how much it's going to cost, since so much has shifted to the outpatient setting.
Well, there are caveats. These are based on averages adjusted for different demographics and other groups. So we do make that clear on the website that if you are high or low risk and so forth, you assign yourself to your own guess of whether or not you are a high or low risk user, and then the costs are averages within each of the carriers and within each of the plans, the different metal levels that it would potentially cost you on average should you buy this premium. So like everything else, the law of averages, you could guess wrong, but hopefully it improves your choice that you guess. If you guess wrong, you are less subject to problems, financial problems, that you still have some good margin of coverage to take care of you.
Well, thank you so much. And if anyone has additional questions for Charles, if you can put them in the Q&A, because what he'll be able to do is answer your questions directly while we go to our next presenter. Thank you so much, Charles. And wow, that was impactful and quite a bit of methodology and work that has gone on. Thank you so much. And now we're going to turn it over to Vanita. And Vanita is going to take us back to Colorado and talk about prescription drug rebates, which is a hot issue. So Vanita?
Thank you very much. Can you hear me?
Yes.
Yeah, terrific. Okay. So this presentation is about our efforts in Colorado to collect information about prescription drug rebates and analyze their impact on overall prescription drug expenditures. Oops. In outline, I'll discuss the impetus for collecting these data, also describe how prescription drug rebates work, and our method for collecting drug rebate data and our findings, and finally discuss some of the policy prescriptions that have been proposed to address some key issues. So prescription drug expenditures, as many of you know, are the fastest growing consumer health expense in the United States, and it's largely due to increases in prices. But measuring prescription drug expenditures is challenging because of the lack of transparency about pricing, and particularly the lack of information or transparency about the impact of manufacturer rebates on expenditures. And here I'm referencing rebates and what we're calling other compensation. And by other compensation, I mean any price concessions that manufacturers give that they may call by another name, not rebates, but some other price concession like a discount. There are also rebates that are labeled something else, but we're trying to be comprehensive in the data that we're collecting, so we're including it all and basically using a definition of rebates that's very all-inclusive. So the objective I've already discussed, so let's just continue and describe how prescription drugs work. So this is a kind of simplified diagram of the supply chain and flow of payments for prescription drugs. So drug manufacturers sell their drugs to wholesalers who then sell those drugs to retail pharmacies. The price at the retail pharmacy is the manufacturer's drug price that's marked up first by the wholesaler and then by the retail pharmacy. Pharmacy benefit managers or PBMs negotiate discounts with those retail pharmacies. These pharmacy benefit managers are groups that manage prescription drug benefits mostly for health plans. And in addition to negotiating these drug prices with retail pharmacies, they also manage or maintain drug formularies. Those are the list of drugs that are covered by the health plan. And they also pay pharmacy claims. In addition, PBMs, or pharmacy benefit managers, negotiate rebates with drug manufacturers. And drug manufacturers, for some of their drugs, pay rebates to the PBM separately and retrospectively to make their drugs preferred drugs on the formulary so that they can increase their sales. So these are preferred drugs where the copayment is typically lower. And so by virtue of lowering that copayment, their sales could be increased. Now, rebates reduce the cost of drugs to the pharmacy benefit manager, and some of these rebate dollars may pass from the pharmacy benefit manager to the health plan. Importantly, it's not clear if those rebate dollars from the health plan are passed through to employers or the purchasers of the health insurance or the prescription drug benefit. And that's an important consideration that we will pick up on. In addition, consumers pay basically the list price or the negotiated amount from the retail pharmacy. The rebates are not used to decrease what the consumer pays here. Now, obviously, they have a copayment, and the health plan picks up a large portion of the costs for that drug. But nevertheless, it's based on the list price, not the list price less the rebate. To continue. Now, rebates reduce, as I mentioned, the retail cost of drugs, but may have a perverse incentive of increasing prescription drug expenditures on a net basis if those rebates increase utilization of higher cost drugs. And I would ask you to keep that in mind because our findings will address this issue directly. And importantly, also as background information, there are legal and market dynamics involved in negotiating rebates with drug manufacturers that differ by payer type. And so as a consequence, in our analysis, we looked at the results of the rebate dollars and their impact on total drug expenditures by payer. Medicaid, importantly, receives the largest rebate as a percentage of total expenditures. And that's due to provisions of the Medicaid drug rebate program. So this is written into law. Rebates for Medicare Part D are typically larger than for commercial payers. It's not as high as Medicaid, but it's larger than what we see for commercial payers because the formularies for Medicare Part D are more restrictive. And so manufacturers have a greater incentive to offer larger rebates to Medicare Part D plans. Interestingly and importantly, rebates for Medicaid and Medicare are reported publicly. That's a public source of information. We can look it up in the aggregate, that is. And these rebates are used to reduce government subsidies, and in the case of Medicare, to reduce the premiums for the Medicare Part D benefit. On the commercial side, however, the information is not as transparent. We don't have information unless we collect it in the way that Colorado has done about the amount of rebates that are paid by drug manufacturers to PBMs and commercial payers. And we don't know what happens to those drug rebate dollars when they are paid to PBMs or health plans. So our analysis, it presents the first public information about rebates paid to commercial payers in Colorado. So just a brief description of how we collected these data. So this was part of a larger state initiative to constrain healthcare costs. So payers were required to submit prescription drug rebate information to our organization, CIVIC, each year beginning last fall. In this process, the approach that we took, the method that we took to collect these data was modeled after the Center for Health Information and Analysis in Massachusetts. They were groundbreaking in pursuing the rebate information, and so we followed their lead. The first submissions included rebate data for 3 years, 2016, 17, and 18. And payers submitted rebate files of drug rebate information based on their data from the pharmacy benefit manager that manages their drug benefit if they had a PBM. They were asked to provide information about prescription drug expenditures, excluding rebates, overall, and by type of drug. And they're also asked to provide prescription drug rebate amounts, again, overall and by type of drug. So here are some results from what we received. And again, we're looking at the results by payer type. So you can see that Medicaid had the highest percentage of rebates of their total drug expenditures. Medicare Part D, both in terms of the fee-for-service individual Part D benefit, as well as the Part D benefit as included in a Medicare Advantage plan, were next highest, and commercial was lowest, although it wasn't very much different from Medicare. So now I want to focus on drug rebates for commercial plans specifically. Here on the left-hand side of the screen, we see the growth in prescription drug rebates as just dollar payments from one year to the next. These are the bars. And then as a percentage of total drug expenditures, this is the trend line. It goes from 11.3 in 2016 to 16.1 in 2018. On the right-hand side, we can see the size and the growth of prescription drug expenditures excluding rebates. And then, by comparison, the size and the growth of prescription drug expenditures net of rebates. And you can see that the size and growth is far less when they are net of rebates. As a matter of fact, the prescription drug expenditures net of rebates were mostly stable. They didn't grow at all. Here is a graph of rebates as a percentage of total expenditures by payer. And we looked at that for 2016, 17, and 18. And you can see that there's wide variation in terms of the percentage rebate by payer. But over the course of time, more payers were receiving a higher percentage of rebates. So that was an interesting finding as well. Now, when we look at the rebates by drug type, again, we're focusing on commercial plans. We can see on the left-hand side of the screen that the rebates, or I should say the total drug expenditures, are highest for brand name drugs. The rebate percentage is also highest for brand name drugs. Next highest was specialty drugs. And for some background, specialty drugs are defined differently by payer. These are drugs that are typically used to treat chronic or life-threatening conditions. They're drugs that require special handling and administration and even patient monitoring. And you see a lot of commercials on television about this, about specialty drugs, and they tend to be very expensive. But brand name drugs have the highest prescription drug rebates and percentages. If we look at the trends over time, though, you can see that the total spending, drug dollars, and rebate percentage has actually increased mostly for specialty drugs. And interestingly, the increase in rebates that we observed were highly correlated with the increase in spending for specialty and non-specialty brand name drugs. Rebates for these drugs grew, as noted here, $59 million, but the spending for these drugs increased by a great deal more. So in summary, prescription drug rebates help offset the cost of prescription drugs. However, it's unclear if commercial payers are passing those savings from rebates and other compensation along to employers and helping them lower prescription drug costs. Our analysis also suggested that rebates may increase the utilization and possibly the price of higher cost drugs, raising overall prescription drug costs over time. So our takeaways are that health plans are not if health plans are not passing rebates on to employers, the employers are paying the full price of more and more expensive drugs. And in the end, while rebates may be a means to reduce prescription drug costs in the short term, they may have a negative impact in the long term. And then finally, the Colorado General Assembly has debated several pieces of legislation in 2020 to address the high cost of prescription drugs. A couple of bills were introduced to achieve manufacturer drug pricing transparency and to expose the portion of rebates that are retained by the PBM or the health plan, and also uncover how rebates are used or passed along to employers to reduce insurance premiums. There are other bills that were considered as well, which I won't go into, but the COVID-19 pandemic unfortunately derailed action on these bills, but they'll likely be taken up again in 2021. And so we hope that the results of this analysis will help determine the outcome of those bills.
Well, thank you, Vanita. And this was it's a very complex subject, especially, and I can't imagine processing all that information. We do have a question, and we have time for only one question right now, and that is the rebate information available at the claim level?
No, it is not. We are collecting it again overall for a payer for their entire prescription drug expenditures and by drug type, generic, brand name, and specialty, but no more detailed than that.
Okay. And I have a sense that that has to be a very complex undertaking but again, congratulations, because for many people, you know, the medications are very expensive, and hopefully that'll trickle down to the consumer and have an effect there as well.
We hope that happens, and we'll see how the legislation that's being proposed fares in the upcoming legislative session, and we're optimistic.
Well, thank you. Thank you so much. And now I'd like to go to the panelists, all the panelists, to wrap this up with just and if we can see you too, just 1 minute about why you think or how you can convince somebody that using data is the right way to go to affect policy. For those that are struggling and trying to get those resources for data, what can you tell them that is really going to turn the corner for them in their state? And we'll start with the way we started. Lisa?
I'd rather actually not go first, if that's okay.
Okay. Angela?
Hi. Yeah, I would show them the report that we just did and that we're about to publish that shows a marked impact from SSPs on county level infectious disease rates. There's really no better example for our state than that specifically.
That was amazing, amazing information. Okay, Charles.
Yes, more data are better is my motto, but more specifically to policymakers, you will get better information about making choices when you see what individual behavior is like aggregated, looking at its total distribution and getting cost data on that will help you in your Medicaid programs, in your restricting costs for employers. There are countless ways that would be amenable to getting an APCD online.
Okay, thank you. Lisa, you ready?
I mean, I think I would look at it from a broader perspective and say a lot of, my dog's visiting, a lot of political decisions are heavily influenced by lobbyists and by opinions, and data is one way to have evidence that most people, not everybody, can agree on as being a solid foundation for political decisions, policy decisions.
Well, you've got a good partner at home to work on these issues with. Thank you. And Vanita.
Yeah, well, the data are critical. I mean, we know that people are having trouble affording their prescription drugs. And we also know that we're not able to really measure prescription drug costs accurately. So how do we get a handle on this? The only way is to collect information and to disseminate that information and to determine, how big, in the case of my presentation, how big those rebates are and how much of an impact they will have on reducing costs for individuals. So this has a real life impact, and it's critically important that we're able to produce information that describes the size of the problem and to help policymakers determine what the right solution and strategies for dealing with these problems might be.
Well, thank you all, because you demonstrated it was convincing demonstrations that data does drive policy, and you can't do the policy without this data, or else you could really mess things up or not even get the answers that you're seeking. So again, thank you all for a wonderful session, and also for all the work you're doing, because it is having an effect and it's benefiting many people. Thank you.
Thank you, everyone. See you this afternoon in the next session.
Thank you.